Okay, welcome everybody. Please have a seat. We will start our session soon. Thank you very much for attending this very important session. First of all, let me introduce myself. My name is Gunadi from Ministry of Health, Indonesia, Universitas Gadjah Mada, Dr. Sajida Hospital. And in this session, we are very grateful that the committee bringing up the very important topic, the genomic research in low-middle income country, including Indonesia. So the session will encourage networking with and among researchers in low-middle income country, identify challenges, opportunities in this setting. If remember when COVID-19 several years ago, then we can finish the pandemic when we are working together, not LMIC left behind. I think this is also important for LMIC to be involved in genomic medicine. And for the first speaker, we invite Dr. Eva Maria from Institute of Human Genetics, National Institute of Health, University of Philippines. She is former president of Asia Pacific Society of Human Genetics. Please, Dr. Eva, time is yours.
Good morning, and thank you for the kind introduction, Dr. Gunadi. Thank you to the organizers for inviting me to share with you about challenges and opportunities for genomics research in limited resource settings. The limited resource settings in this presentation refer to low-middle income countries where a significant proportion of the world's population resides. These are the countries colored pink and purple on this map. The LMICs have a GNI per capita of $4,255 or less. Singapore is definitely not in this category. The total population in LMICs is expected to increase even more, and making research in these populations will be of high global importance. The LMICs face numerous resource as well as capacity constraints impacting on genomics research. What has been written since a decade ago, majority still remain true. However, there have been significant progress in a number of LMI countries. First is the limited number of well-trained genomic scientists. Many developing countries have limited capacities in terms of education and training, especially in highly technical fields such as genomics and bioinformatics. This leads to the lack of personnel trained in genetics, genomics, and bioinformatics who can serve as a core team to plan and develop genomics research and training programs. Once upon a time, scientists from developed countries were the ones doing genomics research, and so postal research and parachute research were the norm. This brought little to no benefit to local institutions, researchers, participants, and this imbalance resulted from an entrenched power asymmetry which undermined the contributions of knowledge of the local experts. This has changed dramatically over the years and perhaps just happening sporadically. Second is the poor infrastructure to conduct genomics research, primarily due to the high cost of establishing and maintaining a genomics sequencing and bioinformatics facility. There's also limited funding. There's also limited funding for the operational expenses due to the rising cost of reagents, consumables, and equipment maintenance. Tools for genomic data manipulation and analysis are not readily available locally, with licensure fees are frequently beyond the capacity of institutions to pay. The insufficient training of personnel limits the use of these facilities. The third is the lack of coherent national policies in most LMICs. Analysis of national guidelines, policies, and procedures from these countries reveal major weaknesses and deficiencies in governance of genomic research as well as in biobanking. And there is a lack of comprehensive ethical legal frameworks to guide data sharing between high-income countries and the low-middle-income countries. Though the LMIC countries, they may be resource limited, but there are unique opportunities available to us. And on this slide, we see some important strategies to overcome the challenges in limited resource settings. First is to develop national genomics policies in order to harness the benefits of genomics-led healthcare, which we have been hearing about repeatedly in this conference. National genomics policies need to be developed, which addresses human and technology capacity development within the context of the country's national economic and sociocultural uniqueness. Second is to prioritize research funds for genomic research. Many LMICs do not put research in their national budget in general. What more, genomics research. So third is to provide access to up-to-date scientific information. Most institutions do not have subscriptions. One suggestion, a possible solution that has been made, is to create central academic libraries that have access to non-open access journals and work on agreements between universities, research centers with scientific publishers to grant access for free or reduced fees. Access to internet should also be part of the solution, especially for countries with geographically isolated and disadvantaged areas. The Philippines is made up of 7,641 islands. Indonesia, 17,508 islands. So internet connectivity should be a priority. Fourth is to create effective tools for genomic education and genomics research capacity building programs such as workshops, seminars, postgraduate courses, as well as massive open online courses. I was so happy to hear about significant developments or progress in this area from speakers from Africa and South America in this conference. And lastly, fostering partnerships and collaborations among academic and research institutions and even with industry to really drive down the cost of doing genomics research. These are examples of two big initiatives from LMICs started many years back that have successfully hurdled these challenges and have fostered genomic research capacity for LMICs by funding locally initiated research and empowering local researchers to lead genomics research projects in Africa and in Mexico. I think Mexico has already moved to an upper middle income group category by now. Global approaches propelled by the WHO can foster translocal replication of successful models by offering a platform for developing guidelines for incorporation of low-cost, high-impact genomic technologies into the healthcare system. Of course, these are only possible if significant population-specific genomics research are conducted. So last April, the WHO Regional Office in the Western Pacific gathered together countries to accelerate access to human genomics. The output of this meeting will be out soon. And these recommendations were mentioned during the plenary talk. The WHO recommends promoting genomics through advocacy, identifying and overcoming the practical issues that impede the implementation of genomics, strengthen collaboration among scientists, healthcare workforce, experts from different fields, and provide effective oversight to promote equitable use and responsible sharing of information obtained from genomics. In the next part, I'll be sharing some of the developments that have happened in our country, the Philippines, currently listed as a low-middle income country. The Department of Science and Technology, as mandated by law, should provide central direction, leadership, and coordination of the scientific and technological efforts of the country. So through the harmonized national research and development agenda, the department ensures that results of science, technology, and innovation endeavors are geared towards and are utilized in areas of maximum economic and social benefit for the people. Fortunately, Omics Technologies for Health is one of the 10 programs under the health cluster. And from 2017 to 2023, the government has provided funding and infrastructure support for genomics and other omics technologies to the amount of $24 million US. The Balik Scientist program of the government also aims to promote information exchange and accelerate the flow of new technology in the country through strengthening the scientific and technological manpower of the academe and public and private institutions. The program's objective is to encourage Filipino scientists and technologists to return and reside in the Philippines and share their expertise for the development of the country. Genomics is one of those benefiting from this program. On July 2009, the Philippine Genome Center was established with support from the University of the Philippines and the Department of Science and Technology. The center serves as a catalyst for the advancement of genomics research and its applications through collaborative and multisectoral partnerships. Our goals include promoting a research agenda that addresses national priorities, train future scientists, and foster links between academic research, government, and industry, as well as provide tools to do genomics research. Efforts towards genomic appreciation include organized tours, visits, roadshows to facilitate knowledge sharing, promote dialogues, and create opportunities for collaborative efforts among research teams and institutions throughout the country. To strengthen stakeholders' engagement, the PGC also holds informative seminars and provide capacity-building training programs for university students, workshops for researchers and professionals, and mentoring has also emerged as a critically important strategy. To help the country realize the full potential of genomics, the PGC is setting up the Philippine Genome Information and Resource Hub, or PhilOmics, an interoperable ecosystem of omics databases where local researchers can store, access, share, and analyze data being generated from various projects and major sequencing efforts in the country. And of course, the PhilOmics will allow us to actively participate and contribute to the Global Alliance for Genomics and Health. We've heard about this from a number of speakers in this conference. The people who established the G4GH are here. And so this broad international participation in building, adopting, and deploying standards and frameworks, global data sharing can be realized and can rapidly advance genomic medicine and ensure that all populations can access its benefit, including the LMICs. For genomics research and services to flourish, there is a need for massive education of the health researchers and clinicians. The Philippines, together with other countries in Asia, benefited from an NHS England organized International Genomics Education and Training Summit last November 2023, led by Professor Dame Sue Hill and Professor Kate Brown, held at the Welcome Genome Campus. And 99 delegates from 49 countries across 6 continents were invited in the summit to gain a collective understanding of the drivers for and barriers to the adoption of genomic medicine, particularly in relation to workforce education and the conduct of research. And a global community was built, committed to share resources for genomics education and training to foster new ideas, forge collaborations, and strengthen and expand connections. Our very first experience on a huge effort for capacity building in genomics research was achieved through the development of an academic and research partnership with developed countries and LMICs. In this collaboration, there was a partnership done by processing of samples in laboratories located in developed countries, which also facilitated advanced training of scientists and students from the LMIC. So more resource countries hosted less resource countries. This is one of the biggest efforts to map the human genetic diversity in Asia. In 1976, a new condition called torsion dystonia in Panay was reported by Filipino neurologists. At that time, it was called dystonia musculorum deformans, and the drawings on the right, on your right, was from the doctor who first saw these patients and their families in a specific region in the Philippines. So this uniquely Filipino disease is known as the dystonia of Panay, is a severe neurodegenerative disease that presents as a movement disorder. Any male, anywhere in the world, who presents with a combination of dystonia and Parkinsonism for sure is Filipino, and his mother has maternal origins in the Panay group of islands. It has a huge burden not only to the patients but also to their families because of the loss of quality of life and productivity, stigma related to its genetic transmission. So the actual disease frequency of XDP remains unknown. We used anonymized residual dried blood spots from our newborn screening program to look for the XDP-associated DNA variant that causes XDP. Working on over 100,000 residual dried blood spots provided a nearly complete unbiased representation of the Filipino population. And this research gives us a comprehensive picture of the prevalence of XDP in the country, and this data can be used to develop health services and allocation of resources that can improve the quality of life for those affected by XDP. This was only possible through a collaboration between the Philippines and the Massachusetts General Hospital Collaborative Center for XDP. No other genetic screening campaign has been performed at this scale by a single nation tackling a rare neurodegenerative disease. This cost-effective and scalable genotyping platform can be used to advance our understanding of diseases that greatly impacts our population, and we now have established the Philippine Disease Screening Laboratory at the Philippine Genome Center. In the rare disease space, the KK Women's and Children's Hospital Singapore invited us to be part of the Genomics for Kids in ASEAN program, which aims to improve access to genomic services for under-resourced families in the region to pave the way for a deeper understanding of undiagnosed rare diseases and diagnostic odysseys. It also aims to increase and strengthen regional capacity and capability in clinical genomics and build an ASEAN rare disease genomic database. The program has been able to establish the infrastructure and workflow for genomic sequencing in collaboration with Malaysia, Indonesia, and the Philippines. So why do collaborations in genomics matter?
The Undiagnosed Disease Hackathon is global kindness in action. Experts from around the world gathered to help some of the most vulnerable children on our planet. Together, generating the new solutions, the new partnerships to help so many. Answers that will bring so many children out of the dark clouds of uncertainty.
Collaboration.
Maharap में सहयोग.
協力しましょう
Kolaboracja.
Collaboração.
Samenwerking.
合作共赢 pakikipagtulungan
Samenwerken.
Collaborations in genomics matter because there are patients, families, and communities whom we serve. And so the key message for this presentation is collaborations, partnerships, sharing of resources are key strategies to overcome the challenges in genomics research in resource-limited settings. Thank you very much for your attention.
Thanks, Eva, for this great presentation on the landscape in the Philippines. And in case you get confused, I am not a speaker. I'm the other co-moderator who, I guess the point is 2 introverted moderators can make 1 extroverted. And so I also am the person who was mentioned by Eva that organized the meeting on human genomics. And I was the person who wrote the recommendation points that Eva put in the document. I'm the head for innovation and research in WHO Regional Office for the Western Pacific. Our regional office is relatively new to this space, and this is actually while I'm here. I would love to learn from most of us. But before that, I would like to introduce the second speaker, Janewit Wongboonsin, a rising nephrologist from Sirija Hospital and Mahidol University. Over to you.
Thank you for the opportunity to talk here. I'm a nephrologist, and I'm going to try to share how I prepare my skill set to actually come back to work in Thailand, which I thought is LMICs. It's actually upper IC, which I don't know if there's any difference. And also, I'm going to share the point of view as a ground young researcher navigating the space in Thailand to show you what are the challenges, both in the system point and then in the biological point that I need to face, and also show you some opportunities that I see doing this type of research in Thailand. These are my disclosures. So tip number 1, stay connected to your friends in Thailand. I did my medical school in Thailand. And as I go through my 9 years in the US, of course, there are so many things that I can branch my career. In Boston, in WashU, in University of Minnesota, I can do dialysis research. I can do, multi-omics research. But getting connected to patients and my staff in Thailand helped me identify what would be the skill set and research materials that I could make a difference. Rather than doing big data research on dialysis where we don't have a data set in Thailand, those skill set would not be usable, right? So stay connected with your mentor, and that really helped shape my career. When I entered Boston, I was fortunate that I get into the training in the year that kidney genetic testing is reimbursable in the US. So all of a sudden, all of the nephrologists get presented with this type of report. Many VUSs, foreign languages that we really do not understand. So that is really the clinical interest that hooked me into the field of genetics. And as I go and read more about genetics, there are GWASs, Mendelian randomization, computational things, and many, many cool stuff that are occurring at the broad, and I get a little bit lost into what I should really shape my career into. So Matt Sampson, my PI and my current mentor in Boston Children, has really gain me keep me focused to start with really what's the end in your mind. If I really want to go back to Thailand, go and learn the skill set that is usable. You might not need to be the expert in every single thing, but you need to know the right person to actually help you gain the skills that you need. So he connected me with people from ClinGen, who is local in Boston, and also with colleagues within nephrology at Mass General and at Brigham to gain the clinical skills that is needed for kidney patients by integrating these genetic tests. So I'm going to give you the toy example of the project that aligned with the goals of my PI and also the skill set that I need to go back to Thailand. Why do I need to care about this, and why would these skill sets be helpful in going back to Thailand? Nowadays, we know that there are so many genetic discovery as well as in the kidney space, and there are many, many genes and risk allele that can actually make a difference in the care of the patients that we had. For the toy example that I used to work on is patients with nephrotic syndrome. We know that children with nephrotic syndrome need a genetic testing to help triage what they need to do for their care. But for adults with nephrotic syndrome, we really don't have a framework of how genetic information would help the care of our patient. So my simple goal is to see of all of these genetic information, how can it help me take care of adult patients with nephrotic syndrome. And I turned into the National Brigham Biobank, where they already stored 130,000 patients. My job is to actually go in there and actually find the right patient, which takes much longer time than what I originally thought. And then once I find those patients that I'm confident that they have nephrotic syndrome, and this is not based on ICD-10, it takes much more effort than that, then I stratify them based on the genetic status, whether they have some pathogenic variant or risk allele, and then see what's the prevalence in adult population, because we usually do not send genetic testing in these populations before, and then see if these genetic variants actually make any difference in the care of the patient. Now, it takes me 3 years in a well-resourced setting, where, in National Brigham, there's already an existing VCF file in the server. But it takes me 3 years in Boston to navigate the way from a young nephrologist who doesn't know anything in genetics to actually get to do this research. So this workflow is just showing you, even in the well-resourced setting, it takes me 3 months to get a DOA to transfer the data from different hospital, to put it on the computer server, to make sure that the pipeline of variant prioritization and filtering is right, and that I'm doing the right variant sign out with the help of my genetic colleagues before I get to do the end result, which is statistical analysis, which is, as an epi background, it's pretty much very straightforward. But when it comes to the biobank scale of data, it is sometimes not as straightforward, and there are limitations into that. So with this 3 years, when I come back to Thailand, I'm not anticipating that I can repeat the work within a shorter time frame, right? I think setting some expectation of how complicated things could be is helpful. And when I come back to Thailand, knowing that there are many, many things that I can make a difference in the kidney space, it's good for me to help shape what kind of project that could be done in the short term and in the long term. And here I'm going to share with you the system and biological challenges that I see when conducting these 3 projects in Thailand. So the lack of personnel really underlies the system challenges that we see. In the clinical research space at National Brigham, I can automatically curate in a program that is created by already very smart people to generate preliminary data for a grant within 3 months. That's not the case in Thailand, right? Most hospitals in Thailand, including my hospital, it's still a paper record. So everything is done manually, right? And proposing things to IRB, we need a case record form for whatever that we don't know what we're going to record, right? So the concept of transitioning into a live case record form is being done, but those are the barriers that young investigators like myself is not as easy to navigate. Bioinformatic infrastructure, it is just becoming a new career in Thailand, right? So when I asked if I gonna have a computer server where I can do Jupyter Notebook in nephrology division, it's totally a foreign concept. Like even in our genetic department, we don't have a Jupyter Notebook. Everything is still done in the local environment. So that is something that I still need to navigate. And what works for my PI in the US is that he's also not an informatic trained person, but he has a co-PI who is really a computational biologist. And together they help to navigate the world of doing this type of research. And that's something that I learned from my PI, and I know that I need to do it, but it's not that easy to find a PhD informatician who will still work in academia in a hospital in Thailand. And lastly, the clinical genomics expertise are quite limited, right? In our country, there are 28 medical geneticists, adult and peds, and they're all full of things to do, right? We can't just ask for all the questions to them all the time. So I have to be confident with some decisions to not overburden the geneticists in our system. Now, coming to the biological challenges, I think I don't need to preach this to the crowd because you are all very familiar with genetics. If we summarize the ACMG criteria into like 3 big buckets of evidence, we all have challenge in both the population data, biological observations, and effect predictions. I'm going to go through some of them in detail, but like for population data, we don't have Thai genomic allele frequency yet that is uploaded. It's being done by someone else. We know that we are not going to have any access to functional data to get to use PS3 confidently in the variant that we see. So let me first focus on the population data. I think the main key thing is that population geneticists is a rare species, and how can we maximally use the data that is going to be generated from Genomic Thailand is somewhat questionable, right? This is one example. Hemoglobin E is a type of beta thalassemia. Right now, the group max allele frequency in NOMAD is 0.9%, and we historically know that in Thailand, the allele frequency is up to 30% in northeastern part of Thailand. So you can imagine that there might be a similar type of variant that we do not know allele frequency can lost through the filter, get filtered, but still labeled as benign, because all of these bioinformatic prioritizations is really proprietary and subjected to each of the lab, right? So there are many, many standardization that could be done, but when we don't have the database, like in NOMAD, it's hard. This variant, if we plot it into the ancestry subpopulation, there is East Asian, there is South Asian. I've always questioned, where is Southeast Asia, right? Will we ever be there? There are laws and regulations that DNA is identifiable, so sometimes it's not transferable. Will there be a postdoc who want to work with people in NOMAD to really do all the necessary QC steps so that we are represented down there? It's not a job of a nephrologist, I think, but I hope that someone in Thailand or someone in this region will be able to harmonize this and bring it up in NOMAD. And that's very important because there are so many smart people that use NOMAD, right? This local ancestry inference, which is the new feature in NOMAD, version 4, is really exemplify the case. This one risk allele of the APOL1 is a protection for trypanosoma, sleeping African illness. It's being very heavily studied in the US. And now with the new NOMAD version 4 release, we can now understand that in Latino American, all of the APOL1 risk allele really exists in the African ancestry haplotype, which biologically it makes sense, and as you all been aware from last talk, the haplotype background do make some difference. These cool features would be very hard to make someone to do it from the ground up in Thailand, right? I think the most efficient way is to actually try to bring our local data to NOMAD, to open the access to everyone in the world to actually use this data and create fun things, variant co-occurrence, PLI, loft score, missense intolerance. Without those incorporation, we can't do it all in Thailand. We need to have other people to help with this. If you're not already aware that in silico predictors a lot of them is trained from reported variant. This is just some lists of the potpourri, your favorite in silico predictors. The one that is endorsed right now is Reveal. And you can see that HGMD, Reveal is trained on HGMD. And if historically in countries that do not have genomic access or genomic variants, and we don't have even a way to report to ClinVar, these training data sets are not trained well, and now we can actually use PP3 up to strong. Should we be confident? Should we not be confident in doing that? It's up to the lab director, right? Whether, how are they going to decide? But knowing the limitation here is one thing, but also trying to make sure that this limitation get a little bit better would be something that countries like us need to think about. Now, stepping into the non-Mendelian world, it's even more complicated, right? I'm not a population geneticist, but if we pick a topic on polygenic risk score, the challenges exist in all steps, from variant detection, discovery, and validation, and also we don't have any non-genetic parameters. For example, SNP array differences. We don't have Thai imputation panel. Everyone impute their panel in TopMed. Would that be accurate? It probably may not be the most accurate, but it's the best that we can do, right? There are limited availability of whole genome sequencing to kind of go over that. And there are nuances in the discovery and validation. So this is just a workflow to show you in case some people haven't worked in PRS. I don't work in PRS a lot, but in a nutshell, you need to have a development data set. You throw in some data sets such as your training data sets. A lot of the people will use UK Biobank. You throw in some clinical variable, and then you plug in the GWAS summary statistic of the trait that you like. And one very important thing to put into this equation is that you need an LD reference panel, because some of these variants that are shown in GWAS, some of them might be in LD, and if you kind of overweight them, it's not gonna be reflecting the biology, right? So you need an LD reference panel to kind of weight these SNPs in the right way. And then you go through some algorithm, and then you select the variant. So there are issues, right? This is the, oh, not yet. And then once you created the the PRSs, then you can regress the parameters to your outcome of interest. For me, it would be end-stage kidney disease, ESRD. This seems very straightforward to do. This is an example of the latest PRS in my field, the CKD PRS in 2022. Let's look at the data that they could put into the equation, right? 70% is from UK Biobank. The LD reference panel is the 1000G. There are 50 Cambodian patients in there. That's it. There's no Thai patients. All right, we're gonna create some score based on that. It's probably not the most accurate, but it is the way to go right now. There are multiple PRSs algorithm. One algorithm that is not used in this paper, but being used elsewhere is like PRS-CSX. And that algorithm actually needed you to confine a patient into one continental population. Usually it is EUR, Europe, African, or Asia. There's no Southeast Asia. There's no way to actually make this into a continuous variable. It's actually a standalone variable. So all of those assumptions that we need to make PRS make me very skeptical of doing all of this, and also to kind of try to make judgment and find associations in this disease. And lastly, for all the PRSs, you probably have seen this graph before, that when we plot all the PRSs with the ancestry background, they have to be calibrated by some mathematical format. And one way to do it is actually to use this complicated formula, which actually, how to use this complicated formula, they infer the data from 1000G again. So even with the latest 2022 way to actually account for PRS's difference, it comes back to using 1000G, which we don't have any representation. To me, it's an epi disaster. There are so many confounders that I need to really make sure that I do not overcall things from the PRS. How about the opportunities? I got to work with several projects here, and I kind of feel excited because I know what are in need and what are the limitations that I would see. For one disease that I'm really happy to work on is the atypical HUS, atypical hemolytic uremic syndrome. There is a drug for this disease. It's out in the market since 2012, but it is just coming to Thailand this August, which is great, but the drug costs around $1 million per year to be given to patients in the US. And a lot of it is that in the US, how we work with these diseases is that once we diagnose the patient with this disease, we give empirical treatment with eculizumab for 3 months until the genetic result come out, and then we stop the treatment for those that doesn't have likely pathogenic variant. I don't think Thailand can afford this approach, right? And there is an economic call for us to actually do rapid genome or rapid gene analysis to actually try to answer this first so that we don't have to kind of pay for unnecessary eculizumab for 3 months. So that's something that I think it's gonna be very good project, but again, it's a multi-institution registry. I need to work with everyone and go through the IRB at the national level. It would take some time. Otherwise, in the kidney gene panel, we want to do all the gene panel ourselves, right? At this time, the cost of the exome is starting to get cheaper, and if we combine with the volume, I think we are at the good place where we can probably skip the gene panel and go straight for exome backbone, which is great because we enter the field later. We don't need to repeat the hassle that come way in the past. But those are the opportunities that we had. And then for patients that are enrolled in Thai genomic projects, there are challenges of patients in genomic Thailand, but there can be rapid clinical translation. And this is one example of the case that, it might not be the best gold standard when compared to the US, but I'm really happy and proud to share about this case. So this patient is an 18-year-old man who actually have a diagnosis of global developmental delay and cerebral palsy that was pretty much undiagnosed. And he got enrolled into genomic Thailand. There's no explanatory genetic variant at that time. Therefore, he's still labeled as we do not know what this phenotype is. Unfortunately, he developed nephrotic syndrome, and as he was 18, he come to my clinic, and when reviewed the nephrology presentation, he actually have a nephritic presentation, meaning he have lower creatinine, he has urine with a lot of dysmorphic red cells. For the nephrologist in the audience, this really looked like something that, not primarily a podocyte, it primarily is something immune related that we need to tackle with heavy immune suppression. Now, when we do the biopsy of this patient, it turns out there is this C-shaped lesion in the kidney biopsy. This C-shaped lesion can either be crescentic glomerulonephritis in the setting of an ANCA negative, or it could also be collapsing lesion. And pathologists are really good at differentiating the two. But in this particular case, even our kidney pathologists have a lot of problem in trying to understand which one is the case, right? I reanalyzed the genome, and we discovered a bug in the program that is used by Genomics Thailand. We lost actually one loss of function variant. So it was not signed out as a positive case before. And now when I discover a loss of function variant, there's another missense variant with a very high alpha missense and Revel score. It's not yet still got to be likely path. It needs, PP4, phenotype specificity. Do I have the gut feeling to call this PP4? Of course, my genetic colleagues had helped to guide me whether this could be done, and then we don't have segregation data at that time, right? Mom and dad is sequenced, but we don't know when it's coming out. But the decision to immune suppress this patient or not has to be made right now. And the immune suppression is heavy. It's either cyclophosphamide and very, very high dose steroid. Therefore, after talking to geneticists and everyone, we decided that this is probably more of a collapsing lesion, even though the kidney histology may not fit appropriately. We stop all the steroid and he get better. So, this is a risky move. This is not a clear certified program, right? This is research use, but it is some opportunity that we can help the patient up front. And of course, there must be ways to regulate and make this more, official, but this is the state where, there are both challenge, risky things, and also opportunities for the patient. Lastly, before I end, is that kidney genetic tests could also be something that could help advance a lot of kidney care as well. Kidney biopsy requires a lot of infrastructures. From the one doing the biopsy, interventional radiologists who can embolize the kidney in case we make the kidney bleed, and also electron microscopy, which is almost solely used by nephrology nowadays, not other field as much, at least in my hospital. So to get an infrastructure to get a kidney biopsy done is very hard. Countries in the blue color actually shows that there are actually more availability of kidney genetic testing than EM or kidney biopsy, and perhaps this could be a way to actually advance other kidney disease care, even if we don't have a kidney biopsy. So with that, I would like to thank you, all my nephrology mentor in the above, in Siriraj Hospital, Brigham, Boston Children, and also the genetic mentors that I've seen in my career. Thank you.
Thank you, Dr. Janet. So, ladies and gentlemen, I'm back because we already shared the honor with Mengji. I have to introduce the third speaker. So, the third speaker, Professor Nicki Tiffin. She is from South African National Bioinformatics Institute, University of Western Cape. She is co-chair of International Health Consortium and G2MC Policy and Advocacy Working Group, and also she is chair of Public Health Alliance for Genomic Epidemiology, Ethics, and Data Sharing. Please, Professor Nicki Tiffin will talk about strategic cohort design for global south, maximizing insight and minimizing costs.
Hi, everyone, and thanks so much for the opportunity. So I'm going to be talking about strategic cohort design for the Global South and kind of sharing with you a bit of a journey we've been on and how we've been tackling some of the challenges that we've faced whilst trying to set up our cohort. So we're at the beginning phases of building a genotyped cohort, which we're calling VCAM. It's a virtual cohort for African multimorbidity. And we use the term virtual because all our follow-up is virtual, it's digital. We see our participants once, and then after that we follow up through the records. And I'll talk a bit more about how we do that as we go. We want to make the best use of our resources, so we're building a cohort that is disease agnostic, and we want to study multimorbidity, including non-communicable diseases and infectious diseases. We're really in a state of epidemiological transition, and we find that in most cases, we can't really look at one without including the other. So we have this nexus of infectious diseases and their medications and how they relate to non-communicable diseases. We're building a discovery cohort that will be hypothesis generating and a validation cohort for testing hypotheses, especially those that are being seen in other populations. And we really want to be flexible, agile, and responsive. So we don't want to commit down only one path of research and not be able to respond to new challenges as they arise. So we've got a very strong baseline of ethical operations to respect and uphold participant autonomy, and I'll be talking more about how we implement that. We have a close relationship with our Department of Health. We have health service delivery is at a provincial level. So our province has about 7.5 million active healthcare clients, and we work closely with that department. We've got a strong lens on benefit sharing, and then also on having a capacity building collaborative model. We also want local data storage and analysis. And we want to be really focused on a primary aim to benefit Africans, to benefit our local populations, to benefit Africans, and of course, in the big picture, to benefit global health. So some of our research strengths, Colette already did the work for me here. We have unique human genome diversity and architecture, and these really much older genomes. When I tease my Global North collaborators, I like to say the rest of the world is just a boring genetic subset of what we have in Africa. Our health challenges are diverse, including NCDs and IDs, as I said, and multimorbidity is sadly very common. And I just put a picture from a paper that was published by Gadjah in Botswana. If you go and have a look there, you'll see it really shows you how diverse we are on the continent. Our contextual challenges, we're low-resourced, we're very reliant for research on foreign funding. We do, of course, have national funding bodies in South Africa, but the demand far outweighs the resources. Our participants often have limited access to healthcare, so we have to be very mindful how we work in the space. And we need to grow our local research capacity for health genomics. So there's stuff going on, it's happening, but we really need to focus on making that, strengthening that. And then we also always working against a historical inequity in research collaborations and pushing back against that, trying to rewrite and renegotiate this kind of relationship between Global South and Global North researchers and funders. So I'm going to talk a little bit about our kind of intentional cohort design. Starting here, this idea that we want to work with multiple risk factors. So we obviously we have genotype data, but then on the phenotype side, we want to work with multiple outcomes and particularly longitudinal outcomes. I think one of our learnings out of the H3 Africa program, for example, is today's kidney disease study control might be next year's case. So we really want to be able to do life course work and to see how things change over time for our participants. So I'm just going to talk through some of the elements, and I'm going to put them together as a challenge, the solution, and then very importantly, how we crafted our informed consent to be able to implement the solution successfully. So you'll see as we go through, I'll repeat this motif of the challenge, the solution, and the informed consent model. I just want to say about the informed consent model that this work was done by Dr. Tsaone Temukhla, who's here with us at this meeting, and it's been published as a REDCap template. So if you're interested in building a similar kind of process for your tiered informed consent, you can go to the GitHub page that we've set up, pull down the template, and you can pop up your own fabulous informed consent protocol. You can modify it to suit your particular context, and it will store your data properly at the end of the day in a nice SQL backend clean database. So no more PDFs that you have to page through to work out who agreed to what. Okay, so let's jump in. Our first challenge was the cost of whole genome sequencing. I mean, we simply can't afford it. And there are also not that many core facilities doing human whole genome sequencing on the continent. It should improve because with, of course, the pandemic, there was a lot of work to build pathogen sequencing capacity, and that can also eventually be repurposed and help us out. But we simply can't afford it. So we're using the H3 Africa Illumina genotyping chip. It's much more affordable. It is African informative. It's about 2.5 million SNPs, and we have an imputation service that we can refer to. And this chip, the way it's designed, takes into consideration the shorter haploblocks that we encounter in the African population, and it's sort of primed with African-specific alleles and variants that we compiled ourselves when designing this chip in the H3 Africa program. And so we ask for informed consent for analysis for genetic factors for health. And in fact, we ask separately for informed consent for ancestry studies because we didn't want to do a kind of, I call it like a bait and switch, where you draw people in. We recruit in health facilities, draw them in for a health study, and then go and do ancestry studies on their data. So we ask them as two separate questions, and I think it's worth commenting here that anecdotally that is the only consent question where people tend to say no. We don't have the same pushback on many other of our questions. So it's just something to bear in mind that not everybody thinks an ancestry study is a fabulous idea. We find, obviously, aversion to blood draws for people who aren't, because we're looking at a population and disease-agnostic approach, we're not dealing with people who are necessarily having clinical interventions, drawing blood anyway. We also can't afford a phlebotomist full-time, and then we also have limits to the labs we can use for DNA prep if we're working with bloods. So we're taking buccal swabs. We take 2 buccal swabs per participant. And then we ask, obviously, for informed consent for sample collection, but we also, at that stage, talk about the fact that we might not prep enough DNA because we're doing it this way, and we might come back to the individuals to ask them to repeat the sample. So we preempt that we could be coming back for more. So benefit sharing, we have these scarce resources for health services and research. And personally, I'm not comfortable with setting up a whole separate health data ecosystem with information that could be used for individuals' health, but that I never get back into the health service. We just don't have that luxury. So benefit sharing is an ethical imperative. And just to flag that we have actually also published a framework to help people design their own benefit sharing programs. So you're welcome to go and have a look there if you want to do benefit sharing, but you're not sure where to start. So, so we have an infrastructure that we're implementing to return actionable results to the health service. At this point, we're looking at returning the results into the health service infrastructure so that it will be clinicians who are presented with the results rather than participants, because we don't have the resources to do the necessary counseling on return at this point. We will be very cautious, and we're building now the actual curated return of findings database. Each variant will be curated one at a time, and we're very cautious to put in the wording about this is a research study, these are possible inferences, don't change clinical practice without further intervention and diagnostic testing. So we're being very mindful about this. And then, of course, we ask our participants for consent to return their genetic findings through the health service. So another big cost for this kind of study can be the sample storage costs. So we made a fairly radical decision that we don't store any samples. We're a data-only service. We also have like very sort of unreliable electricity supplies, and frankly, I don't want the responsibility of biobanking a whole lot of samples when I can't guarantee that they'll be properly cared for. So we don't do any biobanking. We don't have any biobanking costs. We obviously have DNA samples, but at least they can be room stable. It's a little less scary. But what we do is we ask our participants if we can recontact them if there are future studies that they might be eligible for. And in this way, we're actually building a recruitment cohort. So if there's something a hypothesis that's generated out of the cohort that is of interest and needs to be explored further, we can actually design the perfect study based on people's medical records and based on their genotype. And with their permission, we're able to recontact and assemble like really a counterfactual that should be quite elegant. So this is a workaround to not knowing which samples to collect when you don't know what the future studies are, and knowing that you don't have the capacity to collect exhaustive samples, and knowing that you don't have an electricity supply that keeps going. Yeah. Clinical phenotype, so this is really one of our big strengths. Obviously, the challenge is the cost of data collection, and especially if you are going to do a lot of follow-up. And also, the cost of data collection, then recall bias can also be very difficult to manage when you're interviewing people and asking them what their medical conditions are. Data accuracy is a problem. The cost of follow-up visits, we also have quite a migratory population who move in and out of our province. They move around the province. And the cost of follow-up visits and this risk of loss to follow-up is all huge. But we have a fantastic resource. It's a continuity of care resource that has been built. It's a health information exchange for our province. And so I had the absolute honor of being part of the team that built the health information exchange. We have a lot of digital platforms, the health information systems, primary health care, the tertiary health care in the hospitals. We've got our national health laboratory service that does all the lab tests, and we've got dispensing databases. And every night we've got a stored procedure that basically sucks all the data from all of these different resources and platforms, brings them all in. There's a big linkage engine that runs and links all the data to each individual in our patient master index. And that updates daily. So at any time, it's live data as of midnight last night. Yeah, so it's a remarkable resource. It's not electronic medical records. These are kind of routine health data. So who's admitted, how long do they stay, what are the lab tests done, what are the results. It's not EMR, so there's no natural language processing required. So of course we ask our participants if we can access these health data, the digital health data. If they agree, then we get retrospective data. For most people, it's retrospective up to about 10 years. It's relatively clean. And then we also have permission to prospectively update relatively indefinitely. So we're looking at probably 6 monthly updates of the data set. I'm guessing as the data get bigger and bigger, as we grow our cohort, we may switch to annual updates just because it's a bit clunky moving the data around. But this is we've been working with an anonymized research data set of about 180,000 individuals from a particular area near us. It's anonymized and perturbed, and those data have helped us get to grips with how we can build phenotypes from these longitudinal data. So we've got quite a few papers out there from the group that you can also have a look at if you're interested to see how we used it. So this is kind of our structure. This is our pragmatic cohort. This is another way to put it is a cheap and cheerful cohort on a shoestring, but it's still an exciting project, and we do actually believe in it. I just want to talk a little bit about the collaboration model. Not everyone gets why we have this collaboration model, so I'll explain it a little bit. First of all, the digital health that we can access, one of the conditions of accessing those data, obviously there's a whole governance process to go through. It's not like we just ask and get the data. It's very carefully controlled, and we're not allowed to share those onward. If people want to use those data, they need to go to the Department of Health directly. But we also really want to build local capacity. We want to work with researchers who work with our population, or many populations in our area. So our model is collaborative. If people are interested in working with these data, we'll do it in a collaborative process. And if somebody's working on a different condition, then, or a specific condition, then we can collaborate with them. They get the benefit of bringing their samples or participants with the right consent into our big cohort. They can then use the full data, and in that way we can also grow our cohort. So we have ongoing collaborations with diabetes and kidney specialists, and this is helping us to, in our smaller state, to be able to at least look at diabetes and kidney disease. So I think of it as kind of front-loading the cohort with a particular high-burden conditions that we're dealing with. And then, we're in the process of building our collaborative agreement with College, who you heard from yesterday, to extend the pharmacogenomic profile as well, and also with epilepsy genomics team that we work with in Cape Town. And we really want to build capacity and skills for research locally. So if we have international collaborators, we'd rather they came and worked with us and we learned from them. Obviously, as the cohort grows and develops, this model will shift, and we hope in the end to have a TRE, a trusted research environment, but for now we're working on the collaborative model. And this is a way of harnessing our local clinical knowledge as well for appropriate interpretation of findings. So where are we now? We're in the pilot phase. By the end of the year, we'll have our first 1,000 participants with genotype and phenotype data. So this is our proof of principle about we can demonstrate that we can do hypothesis generating and hypothesis testing analyses. We've done this proof of principle with diabetes. We've done it with actually COVID-19 severe outcomes. We know that it's not statistically big enough yet. Our point is to show that it's feasible, it works, we can generate the results. And as I said, we were recruiting at diabetes and kidney disease clinics at Gadjah in Cape Town to kind of enrich for those conditions up front. But we also recruit at our dentistry clinics. The University of the Western Cape has very active dentistry. They see several thousand patients a week at their different clinics, and that's disease agnostic. But there are people there with their mouths open, ready to go. So it's a great place to do disease agnostic recruitment. And also because in the routine health data, we sort of lack healthy men. So it's another place to find healthy men to address bias in the people we see at the health facilities. So I want to say thank you, my fabulous team. So I love all your pictures with like 40 people, your team members. We're 3. So I really want to also say that part of why we can do this, as some of you know, I'm a molecular geneticist, lab scientist by training. I'm also a bioinformaticist. I've worked in bioinformatics, health genomics for a long time. I've also worked in health informatics. So and then I'm also have an MPH in epidemiology. So, and then I also do data governance and ethics as part of my work. Tsane, who's here as well, she's a trained molecular scientist. She's worked in the lab and the health service. She's done a PhD in bioinformatics, worked in bioinformatics, and she's just about through her MPH in epidemiology. And then Irene Machado is our wonderful genetic counselor, who's also a trained molecular geneticist, and she's our patient-facing and participant-facing person. So I think also the only way to do this kind of work in LMICs is you have a fabulous team like this, and they actually just do everything. And if you've seen Tsane's poster here, you'll know she's also now recently a web app developer on top of everything. So I really want to acknowledge through the collaborators and through these amazing people I get to work with, this becomes possible. And then just to acknowledge pilot funding from UKRI MRC that's funded this first, the first 1,000 participants. And then I also had startup funding from the Wellcome Trust through the Sidri Africa Center at UCT, and that was for us to do feasibility and trying out this approach. So thanks for your attention.
Okay, Thank you. We invite all speakers. And Mengji, thank you for accompanying us. So to reduce my nervousness to sit here. So I think we have many questions from the audience, but due to the strict time, we have to choose. Yeah, this is the first question. For you bringing fresh and radical idea on genomic clinic to Thailand, were there some reluctancy by local peer system? Sometimes it's difficult to apply new idea in well-established system in LMIC. I think this for Chen. Please.
Yes, there are certainly reluctancies, especially for people that do not understand genetics yet. I also am reluctant too, because I need to make sure what I do is right? So I'm always skeptical about what I do. Right now, the local support, I'm still on probation in the Thai government, in the Thai hospital. I need to do everything nephrology, dialysis, GN, peritoneal dialysis, transplant, to prove that I should worth exist in Thailand, right? So that's, always the challenge, but I know that I think I'm gonna make a difference. So probably these work as they get to send more patients to me, and I make the difference for their patients and their family through genetic testing. Hopefully they will view that this is just not a genetic test that we do for ourselves. This is actually a quote from one of my attending. We don't do genetic testing to just prove to ourselves that we got the right diagnosis. So, you shouldn't send genetic testing just because you want to know. We can manage these gentlemen and barter as we do not know. So these are the challenges that I need to go through still.
Okay. The next question is for Nicki, I suppose. Could you elaborate more on the benefit sharing approach and how the outcomes have actually improved the overall setup?
Yeah, thanks. That's a great question. So because we're still in this pilot phase, we're still building the infrastructure to return the findings. And we're building a curated set of variants for which we feel comfortable we can return these findings. So the way we're doing it, it's actually a digital approach in a way, in that so the infrastructure for the health information exchange that I mentioned, this is like a Microsoft SQL Server infrastructure. So we're building, we have the data from our participants in SQL databases, or SQL tables, and we're building a variant table that will have the interpretations and the appropriate information that will compile a SQL table that can embed back into the health service. So this is a very digital solution, so that when we go to scale, we're not trying to individually curate any one person's results, but rather we are selecting variants that we think could be useful to return them. So our first set of variants that we're going for is we're matching our highest burden of disease conditions with our national formulary or medicine list, and we're taking essentially the medicines that are most commonly dispensed for the most common conditions, and then curating how we will return that information responsibly for clinicians to act upon. So we're in the building phase, but I'll let you know how it goes as we continue. Yeah.
Thank you. I think the next question to all speakers, starting from Dr. Eva, in low resources setting, how do you convince government, ministry, and funders to dedicate resources to health research on top investing in health services? Please.
This is a very important question. So as far as during the developmental stage of the Philippine Genome Center, there were 3 important outbreaks that happened. That was the dengue outbreak in the country. You have the SARS, and then the H1N1. and outbreak. And so it took the leadership of those who were building the Genome Center to convince the government that genomics can actually provide the solutions for this outbreak, especially in a country where infectious diseases still is a major cause of mortality. Now, of course, during the SARS, the COVID-19 pandemic, the Genome Center has had a huge infusion from the national government to do the variant detection. We were called to the palace. The president of the Philippines requested us to come for a meeting on December 26, 2020, and he asked, can we detect the variants? So we said yes, we have the Genome Center. So they infused about 600 million pesos for us to be able to detect the variants and use it to better inform our travel restrictions. So I think what's happening, like we take on relevant events happening in the country to be able to convince the ministries, the government, to dedicate funds for genomics health research.
Yeah, I'm still pretty young and just came back to Thailand. So my senior mentor has actually gone through 10 years of work to make Genomic Thailand become Genomic Thailand. He can tell me all the stories of how, it was proposed to the government and then the government has changed and then things, get stuck for 4 years. And all I learned from him is that we just need to seize the opportunity that come up front to us and hold it tightly. And we need to feel okay to let it go and move on to when things are not in our way.
Yeah, so thanks. The South African government does have health research funding. It's quite limited. So actually, I would say in our case, what we do is we raise international funding, and in recognition of the fact that, for example, we couldn't set up this cohort without the support of our provincial Department of Health, we actually put in line items to put money into that effort. So whether it's some analyst salary or, so in other words, we just try and get other governments to fund what we're doing and our health service. Thanks.
Thanks, Nicki. I think that's a shared experience in many LMICs. I think I would just take the button and follow up with another question for Nicki. I was wondering if I could elaborate on, you could elaborate on the pushback on consent for ancestry studies. Is this something your team had experienced?
Yeah, so it wasn't something we expected at all. I've always been a little uncomfortable with the potential for harm through ancestry studies because we have so many different populations with quite unique cultures and quite unique genetic origin in Africa, across Africa, and I sort of wouldn't want to impose a story about where groups come from. So this is why we split out the questions. I didn't want people to automatically be included in ancestry just because as researchers we think it's cool, right? I mean, it's super interesting, and I love to read the ancestry studies, but I think it should be a choice of people whether they want to participate in those studies. So in one sense, yes, we didn't expect it, but I guess in another sense, my gut feeling was that these health and ancestry shouldn't be conflated in research, and we need to separate them out. And maybe just the fact that I feel that way maybe means that other people also feel that way. And in fact, Irene was telling us, like, some people got quite agitated when talking about the ancestry study and just saying, absolutely not, they must leave ancestry out of this. I don't want to be, explored for my ancestry. We wondered if sometimes the understanding of ancestry might be confused with parentage or parenting somehow. I think across all cultures, this is always an awkward space when it comes to, genetic testing of families, for example. But yeah, I don't know exactly where it comes from. All I say is that I'm very glad we separated it out so we can respect those preferences. Yeah, thanks.
Thank you, Prof. Nicki. I think I have one question to Eva. Sorry. Stick. Yeah. Yeah, for Eva, there is increased interest in building genomics initiative in Southeast Asian region. What would be most important lesson to remember from your experience?
I think it's trust. You have to trust each other to move forward genomics initiatives in any region, for that matter. It's the trust that brings the partnership. Everyone is on equal footing. Not one is better or leads a consortium or a collaboration. Many of the countries will probably be playing different roles, but then if you build the trust, then everyone is on the same page, that no one will be taking advantage of another in such types of genomic collaborations.
So there's a quite interesting question about genetic literacy. How important is it in your opinion? I guess it's a question to all. And how would you recommend to deal with the issue? Well, it doesn't specify which stakeholders to deal with the issue, but I guess it's open to all. Who would like to begin first? Nicki?
Yeah, sure. So yeah, genetic literacy, it's extremely varied. On one hand, sort of formal genetic literacy is very varied, but on the other hand, I think across so many cultures, there's really an understanding of this idea that you're more likely to be like your parents and other people, right? So we've really tried to hook into that story and say, so genetics, it's like if your parents are tall, maybe you're more likely to be tall. Or if your parents look a certain way, you might be more likely to share their facial features and look a bit like them. And it's the same idea that, that genes drive all these things, and sometimes genes can also help us understand who's more likely to get sick or not. And I don't think this idea of heritability is alien at all. So a lot of it is about how you couch your explanations. But I actually want to shout out to Dr. Vicky Nimbaware, who's here, who does amazing work around genetic literacy and is really pushing the boundaries there and is probably way better to answer this question than I am. So whoever asks this question, I recommend you find her in the tea break and she can tell you a lot more. Thanks.
To me, I think I would wear a clinician hat to try to answer these questions. Working both in the US and Thailand, it's the doctor is the business of trust. And there are so many patients that had, kidney transplant for 10 years and still do not know why the kidney failed and the reason why they take these medications, what they do and what they need to do when they are infected or not. But they still come to see us and they still take the medication. Right. On the other hand, there could be a family where they kind of get anxious over PRSs and just go shopping doctors to try to find the right answer. So if the business of, doing this in the right way is trust, is actually the regulations in my opinion, is the regulation in the country to actually make sure that we are providing trust to our patients. There has to be ways to condemn doctors who overuse genetic information to sell and to get rich. There has to be a way to prosecute them to make sure that we maintain trust overall in the country. And if that's still, at least 90% okay, then not everyone has to understand that we actually have two chromosomes, one from the parent, one from the mom, one from the dad. Even if we fix that, I don't think it would help with the our day-to-day work, but it's the trust.
If there was one silver lining from the pandemic, it's that every every household, every person in a family knows about RT-PCR tests, about molecular, yes, about genes, mutations. So as I would say, that's a silver lining from the pandemic. And now introducing tests, actually, I think that many people, even the general public, know a bit more about genes and mutations. But now that we're going to move into doing our own the Filipino Genome Sequencing Project, we're learning from from other countries who have been there and done that, in the sense that they've like 100,000, the UK 100,000 project have a lot of materials for public engagement, and they're available for us to access, and we can probably convert it to to the Filipino language. And we also learned from John Chambers from the UK, the Singapore 10K project, how they did public engagement so that more people will know about genetics and genomics and how it can be useful for their health.
Thank you, Eva. And I think this is the last question, and very challenging question. Any big pharma interest in supporting the effort in LMIC to push for new discovery that ultimately can be arise? Please.
Yeah, sure. I'm sure there's lots of big pharma interest in African genomes. I guess the question that maybe if I can reframe it is there big pharma interest in supporting the efforts of LMICs that are acceptable on our terms? So, you know, any big pharma in the room can talk to me later. Yeah. Thanks.
Well, with my limited experience, right, pharmas have their own goals. They are funding genetic testing for atypical HUS for Thailand because they want to sell eculizumab, right? So we need to understand where they're coming from and what we need. And they're not evil, but we need to work together, right, to actually make this become something that we can use for our patient.
Yes, we look forward to partnership with more like industry, probably not pharma yet, at least for the Philippines. Industry, I'm talking about industry in the sense that maybe if we enter into some form of partnership, this can drive down the cost of reagents, equipment, as well as like even maintenance of equipment, which are really making us suffer a lot. Sorry, say that.
I think we can still get a question. So if I can prioritize, because there are actually, I think, 8 more. We only have 2 minutes and 30 seconds. Let me take my chance. The next question for all is, how do we, apology, these are all very good questions and it's very difficult for me right now. To all speakers, how challenging is it for you to collaborate and share data from indigenous groups? Yes, I always go from the closest.
Okay. Yeah, so I think for us, I mean, just to say, so in our context, we refer to African populations, because I think everyone in Africa, in African populations are kind of from Africa. So it's not a term that we use, so just to clarify that. But I think something about Africa is that almost every population group is identifiable in that they have a geographic location. So if you talk about the Machipili people from Zimbabwe, we know who those people are and we know where they live. So I think the potential for community harm becomes much greater. And in fact, in other work we do, we've decided that until you absolutely have to identify the population group in Africa, you should just talk about a population from Zimbabwe. Because the possibility of doing community harm by reporting, it's not the same as saying for a Caucasian population, which could be any population from up there to down there on the globe. So yeah, it's an area of high sensitivity and one that often people outside the space don't realize is an area of high sensitivity. So yeah, data sharing, it's one in which we have to watch out for community harms as well as individual harms. Thanks.
Quickly, 22 seconds to go. In the Philippines, there are policies in place. There is a National Commission on Indigenous Peoples. We go through the process so that we can, including all this sharing of data from indigenous peoples.
So for me, I mean, Genomic Thailand has the deliverable, and we can't, by the first phase, recruit all the indigenous people in the mountains. So that's what I asked, LC issues, how we would address it. The first phase of Genomic Thailand, they really need to make some deliverable. And then once people see things that are get from the first phase, then the effort is going to be made in the second phase.
Okay, thank you all participants. Due to limitation of time, big applause to speakers.